Okay, so the people that are going to be on the presentation today, on the webinar, first of all, we've got John Grant Casey, who's a Programme Manager of the NCA of Blood Transfusion for NHS Blood and Transplant. Hello, John. Hi there, we've got Mike Murphy, Professor Mike Murphy, I beg your pardon, Mike. He's a Professor of Transfusion Medicine at the University of Oxford and a Consultant Haematologist for NHSBT, and is at the Oxford University Hospitals NHS Trust as well. We have Andrew Charlton, who's a Consultant Haematologist in NHSBT and at Newcastle Hospitals. Helen New is a Consultant in Pediatric Transfusion Medicine at NHSBT. Dr. Lisa Escott is a Consultant Haematologist and an Associate Professor of Haematology and Transfusion Medicine at the University of Oxford, and the Clinical Lead for the National Comparative Audit in Blood Transfusion and Director of the NHSBT Clinical Trials Unit. We have Dr. Paul and Bolton Max, previous SHOT Medical Director, who's currently still the SHOT-NCA WEG member. And of course, we have our current Medical Director, Dr. Shruti Narayan, who's our current SHOT Medical Director. We'll just have the next slide, please. Okay, so first of all, before we do start, I just want to thank everybody that's on the webinar today for your hard work over the last few years, particularly in such challenging circumstances with COVID and all the surrounding difficulties with that, and for your reporting in haemovigilance as well. Next slide. So the outline for this webinar, we're going to have an overview of the National Comparative Audits. 3 presenters are going to give us highlights on 3 recent national audits. It's going to be in some insights from the annual SHOT report, and as I said earlier, there will be panel and discussion and questions at the end. So please do put your questions in the Q&A box, and we'll endeavour to answer those as much as possible. So I'm now going to hand over to John Grant Casey, who's going to start the presentation. Thank you, John.
John, you're on mute.
That's an excellent start. So I'll start all over again. Good afternoon and welcome to the National Comparative Audit Blood Transfusion Program slideshow presentation. My name is John Grant Casey, and I'm telling you here about the program which started just over 20 years ago now. And what we do in the program is we look at how people in the independent and the public health sector hospitals in the UK use blood and use other products as well, such as fresh frozen plasma, cryoprecipitate and platelets, for example. And we look at the quality of the decisions made to transfuse and transfusion practice by healthcare professionals. 2 reasons, really. We're aiming to improve the lives and save lives of people who receive transfusions by making sure they get the appropriate products at the appropriate time. At the same time, we're hoping to be able to conserve the blood supply by making sure that people don't get transfusions unnecessarily. So that's what we're about. And as you can see on this slide there, we've been going now since about 2002, so we're in our 20th year, and we aim to offer about 2 or 3 national comparative audits per year. Now, national comparative audits are really large-scale clinical audits, and for those unfamiliar with that, a clinical audit is really a study of how healthcare professionals are working in a given hospital or healthcare provider. And we monitor their practice against known guidelines or indications of what quality care looks like. The difference between a national comparative audit is that we present those participating hospitals with data that enables to see how they compare with the rest of the country, and also in many cases how they compare with their regional peers. The whole idea being that they can improve the quality of the practice. Now, this audit program is funded through the cost of blood, so it's totally funded by NHS Blood and Transplant, and we're lucky enough over the last 20 years to get about 80 to 90% of NHS trusts and about 65% of hospitals, independent hospitals, joining it. So that means we've got a large amount of data which we collect. And next slide, please. So the way we organize ourselves is that we have a steering group which consists of all the moral colleges, societies and associations relevant to transfusion, and we involve our sister services in Northern Ireland, Scotland and Wales as well, and they all have an input into the programme to help us decide what's important to audit and what we need to consider in the years ahead. While we started off looking at the way in which various blood components were used, today's audit programme really focuses on patient blood management and how well we're carrying out the PBM activities in order to optimize the patient prior to transfusion and manage bleeding and manage anemia. And because we've been collecting data for so long now, we've been very privileged to be able to contribute findings to guidelines such as the British Society for Haematology and so on. And in some cases, we've got the largest data sets ever collected in the history of medicine, which means that we're very, very pleased to be able to share these data with sites. And the final slide, please. So this year, looking ahead to what we're going to do, we're going to be having a look at the audit of upper gastrointestinal bleeding. It's something we looked at in 2007, time to do that again. And also we're having a look for the first time at the way in which children who are coming in for elective surgery are having their anemia managed, because we think a great number of children are coming for surgery while they're anemic, potentially therefore having to be transfused, potentially being able to have that transfusion avoided if their anemia is managed properly. Now, if you want to find out more about the program, then please do contact me. There's my phone number on the screen, and you're very, very welcome to email me at the email address shown, and I'll be very happy to be able to give you more details about our exciting program. So thank you, Simon. That's all I have to say on that one.
Thank you. It's Mike Murphy here, and I'm going to talk to you about the 2021 audit of the NICE quality standards. In a presentation I gave, go back to the previous slide, please. We're not quite there yet. In a presentation I gave at the Transfusion 2024 seminar in March 2020, I suggested the development of a self-assessment tool for patient blood management, PBM, as a means of promoting its implementation in hospitals. And this was incorporated in the Transfusion 2024 plan. The obvious starting point for this self-assessment was a national baseline audit of compliance with the NICE quality standards for transfusion, which were developed from the 2015 NICE guidelines. Such an audit would allow an understanding of compliance with some key parameters of the quality of transfusion practice in hospitals. It would also allow progress in implementing PBM in individual hospitals to be benchmarked with other hospitals, and that information can be used by hospitals to obtain any further resources for its implementation. Next slide, please. So this shows the NICE quality standards for transfusion, and the audit standards for the audit that we carried out were amended slightly from these quality standards. And the audit standards for this audit are shown here. So quality statement 1, people with iron deficiency anemia are treated with iron supplementation before surgery. Adults who are having surgery and expected to have moderate blood loss receive tranexamic acid. So that moderate blood loss is over 500 mils of blood loss. Quality statement 3, patients are clinically reassessed and have their hemoglobin levels checked after each unit of red cells transfused, unless they are bleeding or are on a chronic transfusion program. And quality statement 4, people who have had a transfusion are given verbal and written information about blood transfusion, and that's documented. So John Grant Casey is going to describe the results of the audit, and then I'm going to make some comments about the results. So over to you, John.
Many thanks, Mike. So before I talk about those results, let me just remind you that these SHOT guidelines now came out just over 5.5 years ago in 2016. So when guidelines come out, we expect to give them some time to embed. So if we audit too early, we're not going to see very much in the way of results. But 5.5 years, yeah, I'm sure Mike Murphy would agree, is plenty of time to get these things embedded. So look at these results now. So a little over 6 out of 10 patients who could have had iron started before their surgery had that, so 4 out of 10 didn't. Here we go again, about 7 out of 10 patients who could have received tranexamic acid because they were expected to bleed in the surgery, would have benefited from the use of that drug. They didn't get it, only 7 out of 10 did. About, again, 6 out of 10 people being reassessed here and having their hemoglobin checked, but after each unit of cells was transfused. And finally, with QS4, perhaps quite a disappointing 1 out of 4 patients being given both written and verbal information. So important, of course, for the consent process. So Mike, some encouraging results there, but would you say a long way to go yet before we get to achieving excellent care?
Yeah, thanks very much, John, and thanks for reminding us that the NICE quality standards were published 5 years ago. And I agree with you, while it is encouraging to see some uptake of the guidance, as evidenced by the data in the report, there is nevertheless a long way to go to ensure full compliance and to indicate to us that transfusion practice is optimized for the benefit of patients. What is now needed is for hospitals to understand what has enabled those who have performed well to perform well, and what of those, and for those who have not performed well, what has prevented them from doing better. So what we plan to do now is to devise a scoring system for compliance with each of the 4 quality standards and survey a sample of hospitals who have performed well and who have performed not so well to find out what has enabled them to perform well or from doing better. The learning points will then be shared with all hospitals, the National Transfusion Committee and NHSBT to consider how good practice can be implemented better. We also plan to share the data with a model hospital, maybe along with some further data like from the Blood Stocks Management Scheme on wastage to facilitate benchmarking between hospitals. And we also plan to develop a self-assessment tool so that individual hospitals and perhaps regions can repeat the audit whenever they like, and they do not need to wait until the next national audit to determine if improvement is being achieved. So much work to do. Thank you to those who participated in the audit. Thank you very much to the project group for leading this audit. I think it's been very valuable, but clearly there is more work to do. And I'm happy now to hand over for you to hear about the next audit. Thank you.
Thanks, Mike. Thanks, John, for that great summary, really interesting findings. And we'll be able to see in this short summary of the next audit, I'm going to present a little bit of comparison from the population we looked at for some of those standards that were audited in Mike's audit. So we're going to look at the 2019 re-audit of the medical use of red cells. So it was a re-audit because the original one was done about 8 years ago by the NCA scheme, and so we've been able to look at a little bit of change between those two audits, although you'll see that they weren't quite the same. So we've got some comparison we can make, but not on everything that was checked last time. Thinking about what we were trying to accomplish, well, we're looking at medical use of blood. So this is blood either where the decision's been made by a physician or under the supervision of a physician, to try and reduce variation and look at quality of the decision making and improving the risk to patients. Looking at representative sample of physician decisions, and you'll see the standards that we used to measure those against. We also gathered a bit more information around the patients that were being transfused, the clinical picture, the comorbidity, what tests were done, in order to try and understand why decisions were made. And you'll know from National Comparative Audits that what we're really trying to do is understand, were there reasons that we couldn't measure necessarily why this decision was made. Together with the Royal College of Physicians, and of course primarily by physicians themselves, we want to look at which areas of practice are amenable to change, how can we help with that, how can we provide data to help with that, and hopefully this audit will be one of the good sources for physicians to look at in their own hospitals, and then giving people a national picture of a benchmark basically for physician-led transfusion. So in this 2019 audit then, basically this was adult patients transfused under the direction of a physician, but it didn't have to be a physician or general medical problem that the patient had, because of course this was representing all the patients that come in under the care of a physician. So for example, there's gynae bleeding in there, and that's because some people were admitted for whatever reason to a medical admissions unit through A&E or directly there, and then it turned out that the reason they were transfused was because they had gynae bleeding as the clinical problem. So they're not all medical reasons for transfusion. How does it differ from 2011, which I mentioned before? Well, there are process differences in the way the audit was done, and there are also patient differences in who was audited. So we didn't look at any major hemorrhage, or we asked people not to send us examples of major hemorrhage, and we define that as more than 4 units in 24 hours, because we've had, in the last few years, a National Comparative Audit of the management of major hemorrhage. We didn't want to look at that again. And the decisions that are made and the laboratory parameters and clinical parameters that are used when major hemorrhage calls are made are very different from sort of more elective transfusion, as you'll know. We did end up with some patients who had more than 4 units transfused, but they were felt by the auditors in the hospitals to have been sort of slower bleeding, perhaps someone who required that number over 24 hours but wasn't considered to be having a major hemorrhage, but there weren't a lot of those. Another major difference from the last audit is that we asked people not to send us information about heme-oncology transfusion. And again, you can probably understand the reasons for that. The indications for transfusion and what you're trying to accomplish with transfusion in a heme-oncology patient is a bit different to what's trying to be accomplished with a general medical patient. So we asked people not to send us those. And those patients comprised about 1/3 of the patients that were audited in 2011. We asked people not to send us hemoglobinopathy patient data, and again, that's because the reasons for transfusing them and what you're trying to accomplish in terms of symptoms and life is different from what's perhaps being accomplished with general medical transfusion. And then there had been a deep dive second part of the audit in 2011 where a sample of the submitted cases were actually looked at in much greater detail, and a decision was made using an algorithm. Was this an appropriate transfusion? Possibly or possibly not. And we didn't do that this time around. So I'll show you some of the key findings here. You'll see at the top there, just on the left-hand side, at the top of that dark column, the national one. So 5,155 transfusions that were audited. Median age of the patient, 75. So that's slightly older than what we usually find when we look at red cell transfusion on average across all populations. So we're looking at the older end of the spectrum here, and that's probably what you would consider that would be in keeping with kind of general medical population. You can see, again, not a surprise, 60% of the people who are being admitted have significant comorbidities that may have impacted on the decision to transfuse them. And then 2/3 of people, almost exactly, had some sort of symptomatic anemia. And I won't go into the different ways we define that, but you can see that there are different categories of symptoms defined there. Okay, and then I just want to point out a couple of things here about the documented cause of the anemia. So this is by the end of the patient's stay. So what we asked the auditor was, well, by the end of the sort of patient admission, what was the documented cause of the anemia that they were transfused for in the end? And you can see, I'm going to highlight just a couple of things from this table. The first thing is that at the top there, you can see that iron deficiency was documented as the cause in 20% of the transfusions that were given. I think if you click, there'll be a highlight on that. So that's a significant number of transfusions, isn't it, where it was felt that iron deficiency was the reason for the anemia. Now, it was difficult to know exactly why people had called it iron deficiency. So, for example, if someone had a GI cancer and they were oozing blood, then eventually, of course, they do become iron deficient and therefore may end up needing a transfusion, but probably wouldn't have considered that the clinical reason for transfusion, but they may have been categorized under that heading. So we do need to try and think, what might be in there in that category. So we did a very basic analysis just to think carefully, because of course we want to be avoiding transfusing iron deficiency if we can. Of course, there may be times where it is necessary to give red cells in that setting while you're waiting for iron to take effect. But we looked at these, and in a basic analysis, 2/3 of these patients who were categorized as being iron deficient as the reason for their transfusion did not present with a bleeding phenotype. So that's really important. So these are people not presenting with acute bleeding. And you might think of acute bleeding as a reason why someone with iron deficiency might get transfused. So we need to look really carefully at the cases that were submitted from our hospitals there to just decide, did this patient really need to get red cells, or could we have managed this a different way? The second thing I've just highlighted here, and again, these are highlights of the audits, as you know, just a broad overview, is that nearly 5% of the cases that were transfused were for B12 or folate deficiency, or combination of both. So again, as you'll know, B12 and folate deficiency presenting so acutely that it requires red cell transfusion is really unusual. So we just need to, again, if we were a hospital that submitted one of those cases, just need to have a look and say, did this patient really need to get red cells, or could we have managed them with hematinic supplementation? Okay, so let's have a look at the standards that we actually looked at. So we asked people, did they have a pre-transfusion hemoglobin? And we wanted to see that in 100% of cases for obvious reasons, if an elective decision is being made to transfuse. And you can see highlighted there, 96% nationally of audited patients had a pre-transfusion HB within 3 days. So the reason we allowed 3 days is, of course, if someone has a full blood count done by the GP, or done in say they come into medical admissions and they're not feeling well, they have a full blood count done, hemoglobin's really low, but then they're brought back the next day or within the next couple of days for a transfusion on, say, the ambulatory care unit, then we would consider that to be a reasonable interval. So it wasn't all transfusion done on the same day as hemoglobin. So this standard is around the NG24 NICE guidelines from 2015, from which the quality standards Mike talked about were drawn. So these recommend considering a restrictive transfusion threshold in 2 groups of patients. One group of patients is people who don't have an acute coronary syndrome, so people not presenting with acute angina or heart attack, that in non-bleeding patients, that these people should have a restrictive threshold of 70 grams per litre used. And we allowed in this an other clinical reason why you might consider transfusing the patient. So for the purposes of the audit, what we said is, well, someone might come in with a hemoglobin, say 75, but they've either got moderate or severe symptoms of anemia, which someone's going to look at the end of the bed and immediately say, well, this person's symptomatically anemic, I'm going to transfuse them. So we allowed that as part of this standard. So these aren't exact audit. It's not an exact audit of the standards themselves. It's adapted from those standards. But you can see that even allowing for that within the population, that nearly 1 in 3 patients in that category didn't have an apparent adequate clinical reason for the transfusion. So they didn't have moderate or severe symptoms, but they had a hemoglobin of greater than 70 when the decision was made to transfuse them. So we don't know why that is, but that needs to be looked at by the hospitals that submitted those. And equally, patients with ACS, or we allow cardiorespiratory disease as well, as a reason why people might have considered a threshold of greater than 80 grams per litre. And again, this is about 1 in 5 patients transfused in that category. We couldn't see a reason why they weren't symptomatically anemic. They didn't have other significant comorbidities that affected the decision as far as we know. Then we asked, well, do people know what's happening when they transfuse and what effect it's having? So did people have a post-transfusion HB within 3 days? And you can see there 90% of people did. And you can think of some reasons that are perfectly reasonable why people wouldn't have had a post-transfusion hemoglobin in some cases. So it's good to see that. Then we asked, well, if you're getting multiple units transfused, so you're more than 1 unit transfusion, and you're not bleeding, then is there evidence that people are clinically reassessed and having a hemoglobin level checked? So that's part of those standards that we looked at and Mike briefly mentioned earlier. and also not on a chronic transfusion program as well. So of course those groups have different reasons why you give multiple units in one sitting. You can see here that 1 in 5 patients who were receiving multi-transfusion had their hemoglobin checked in between those units. So we're thinking about, why give 2 when 1 will do? Think about rechecking in between units. Maybe 1 is enough. So only 1 in 5 people are having that checked, and then about 1 in 4 people are having a clinical reassessment documented. This is of course relying on documentation being in the notes or the electronic clinical record. So much room for improvement there, it looks like. And then finally, did people have the risk, benefits and alternatives to transfusion explained to them, either on this occasion or a previous occasion? So we allowed it if people had it done recently. And about half of people had that explained to them and documentation of that. And that's broadly similar to what Mike presented. And you can see there where we've adopted those standards from. Other findings of interest, just to finally conclude. So interestingly, 50% of transfusions were single unit. So if we compare that to 2011, it was about 10%. So a big shift in the use of single unit transfusion. About 40% of people are getting 2 units, but only a small number 3 units or more. So that's very heartening. Looks like we've got a move towards single unit transfusion. As I say, we can't directly compare the statistics because the groups of people that were looked at were different, but even allowing for that, we think there's probably a significant shift towards single unit transfusion in physician-led transfusion decisions. The other thing to highlight, of course, is that we don't know how many people were appropriately not transfused. So perhaps people, there were lots of people with a hemoglobin over 70 or over 80 with cardiac disease, where someone said, well, do you know what, let's not transfuse this person. And of course, we couldn't measure that because we were measuring people who were transfused. So we don't know what the other population is. So in conclusion then, most people transfused in medical settings have got pre and post hemoglobin levels checked. A significant minority though are apparently not being transfused using recognized thresholds, and that's even, we gave people every benefit of the doubt that we could to try and understand why they might have chosen to do that. There are more single unit transfusions in use now, but still lots of multi-unit transfusions in non-emergency cases. We've got a significant majority of iron deficient transfused patients weren't bleeding when they presented, so we're trying to understand why were those people transfused, why wasn't iron supplementation enough? And then only half of transfusions had documentation of risk, benefits and alternatives. And thanks to the project group you can see here, and hopefully now we'll be able to move on and hear about the next audit. Thanks very much.
Thank you, that was very interesting. So I'm following on to present the findings of the 2018 audit on the use of fresh frozen plasma, cryoprecipitate and transfusions for bleeding in neonates and older children. The aims of the audit were to ascertain how FFP and cryoprecipitate are used for prophylactic transfusion in this age group, to understand the management of bleeding episodes in children, including implementation of major hemorrhage protocols, to compare practice with national recommendations, to identify clinical areas where further quality improvement initiatives should be targeted. I'm going to present some of the key findings of the audit in the context of our current UK BSH Pediatric Transfusion Guidelines published in 2016. The link to the full report is on the next slide, and there you'll find more detail and commentary, together with a suggested practical local action plan template, which may be of benefit. So if I could have the next slide, please. So the first few slides are presenting the key findings of prophylactic FFP and cryoprecipitate use in children of all ages under 18 years. Most, but not all sites transfusing the relevant age groups had local transfusion policies or guidelines. That was 87.3% of sites with a neonatal unit for neonates and 83.3% of relevant sites with a guideline for children. The BSH guidelines state that hospitals should have clear guidelines on transfusion thresholds for different paediatric groups, and these guidelines will help clinicians and laboratory staff improving standardization of practice and the quality of care. 26.3% of sites had policies of routinely checking coagulation screens on all preterm neonates. Now, the BSH guidelines state that a policy of routine coagulation screening is inappropriate because results can be difficult to interpret in neonates, and routine testing may therefore lead to increased transfusion of FFP without benefit. Neonatal coagulation screen testing should be initiated really by a clinical picture suggesting a bleeding problem, as there's no evidence to support routine testing, and as I've said, that may increase the risk of unnecessary FFP transfusion. Have the next slide. So what about the findings of the clinical audit? Well, about half of all the FFP transfusions, prophylactic transfusions, were on neonatal units. So they're a very highly represented group. And 76% of the neonates were transfused prophylactic FFP for abnormal coagulation in the absence of surgery or invasive procedure. We looked to see what was meant, if you look actually at the results that were presented in terms of this abnormal coagulation. And for the we found that 23.2% of the neonates who were stated to have abnormal coagulation and who had a coagulation test reported in the 24 hours prior to transfusion had an INR or prothrombin ratio of less than 1.5, so therefore not really significantly abnormal. The BSH guidelines recommend that there is no evidence to support the routine use of FFP to try to correct abnormalities of the coagulation screen alone in non-bleeding neonates. But despite this guideline, the audit identified that there was a common reporting of this indication. So this is really a key area to target practice improvement. Prevention of intraventricular hemorrhage, which is a key concern for neonatologists for preterm babies, was given as an additional reason for transfusion for a third of all the prophylactic FFP transfused for so-called abnormal coagulation in the absence of invasive procedure or surgery. And the BSH guidelines recommend that FFP should not be used either for simple volume replacement or routinely for prevention of intraventricular hemorrhage. There is randomized trial evidence that routine transfusion of FFP doesn't help to prevent intraventricular hemorrhage in neonates. Finally, on this section of the audit, what about the volumes of FFP and cryoprecipitate that was transfused in non-bleeding children? Well, this was more than 20 mils per kilo for 17.6% of FFP transfusions and more than 10 mils per kilo for 31.7% of cryoprecipitate where data were available. The BSH guidelines, despite there not being firm evidence for volumes of transfusion of FFP or cryoprecipitate, suggest volumes for FFP between 15 to 20 mils per kilo, using the higher volumes, particularly in bleeding patients, and for cryoprecipitate 5 to 10 mils per kilo. And these are suggested transfusion volumes, as I say, and the guidelines indicate that care should be taken to avoid volume overload. So this is a point to note in view of the percentage of transfusions that were above these suggested guidelines. Have the next slide, please. So the second part of the audit was around looking at transfusions for bleeding in children under 18 years of age. And we looked at the existence of the major hemorrhage protocol on sites, and 28.1% of sites had no major hemorrhage protocol for children as distinct from adults. The BSH guidelines state that hospitals which may encounter children with massive blood loss should have a dedicated children's major blood loss guideline and an algorithm including transfusion and clinical guidance. Major hemorrhage in children will be rare for many hospitals, and a pediatric MHP will help guide transfusion management and laboratory communication, reducing the risk of potentially life-threatening delays or errors in volumes for administration in an emergency. And template pediatric MHPs are available, useful as a basis for a local MHP. Clinicians should have a low threshold to activate the MHP in cases of suspected major bleeding for children. But for the clinical audit, we found that children with major hemorrhage, the MHP was only activated in 55.6% of cases. And failure to activate the MHP in such situations can lead to delayed transfusion and death, as has been stated by SHOT following reports. Education should be provided to ensure that clinicians and laboratory staff understand how and where to access the information in local pediatric MHPs. For those sites that had an MHP, tranexamic acid use was not included in 17.5% of sites. And according to BSH guidelines, tranexamic acid should be used where massive blood loss is anticipated in children presenting with major traumatic injuries. Essentially, there is evidence both in adults and children that tranexamic acid can reduce blood loss, and it's recommended for massive blood loss, for example, following pediatric trauma, and guidance on its use should be included in MHPs. Finally, 40.4% of sites did not have a concessionary release policy for the use of acceptable alternatives to pediatric blood components in emergencies for major bleeding. And in order to avoid delays in blood provision, BSH guidelines recommend using pre-agreed hierarchies of alternative components in case specific blood components are not available in an emergency. This reduces the risk of confusion or delays in laboratory provision of appropriate blood components, particularly for neonates. So I hope these key points have given you a flavour of the findings of the audit and key areas to focus on for the further local quality improvement initiatives. As I say, more details are given in the main report, together with a suggested chart of actions that one might take. This slide shows the members of the expert project group, and I'd like to thank again the many people in the hospitals filling in the details and sending in their results locally.
Thanks very much, Helen. And moving to the last few minutes of this presentation before we open up for panel discussion, we just wanted to provide some insights from what we have gathered from the reports submitted to SHOT. And just to summarize, people maybe, as people are aware, SHOT is the UK haemovigilance system, which is independent and professionally led, and reporting is confidential and anonymized, and it is professionally mandated. Now, I would also like to actually highlight that everything that we have discussed here is from the reports that have already happened, but SHOT also includes near-miss reporting, and now we've also started the learning from excellence as well, so combining both the safety 1 and the safety 2 approaches. And it's also important to recognize, actually, patient blood management as well as haemovigilance are two sides of the same coin. We have spoken about the National Comparative Audits, but here we also actually, there are SHOT reportable events relating to avoidable transfusion, delays transfusion, and that Paula will be covering the next couple of slides. And that is an ongoing exercise, which is actually then going to actually tell us about how much of an improvement has actually happened in the patient blood management practices. And based on these, we have been emphasizing the last few years as to how this was one of our key recommendations as well. When we are making these transfusion decisions, you need to be able to weigh the risks as well as the benefits and consider alternatives and involve the patients. It should be a patient-driven transfusion safety. And there is an A to E decision tree, which is elaborated further in our report as well, going through simple steps about how you're assessing the patient, looking at the whole picture, looking at the trends, and making sure that you're having the consent of the patient and not forgetting other measures, the PBM measures that need to be put in place. Also important is about the documentation. So, this is actually just a simple guide to actually help make the transfusion decisions. And also, the consent guidelines, we are all aware, as was mentioned by Mike and my colleagues as well, that, from the SAPTO, there has been an updated guideline produced in December 2020. This has also been actually alluded in the 2020 SHOT report as well, and just goes through all the key principles that one needs to consider when you're discussing with the patients. I'll hand you over to Paula to actually then cover the next couple of slides that would cover the avoidable transfusions that we see relating to the audit results that we that has been presented. Over to you, Paula.
Thanks very much. And it's interesting to see how SHOT reporting, in a sense, helps to drive the topics that are chosen for national audit. So transfusing wisely is really a subdivision of choosing wisely, which is an international campaign to try and avoid patients getting treatment that they really don't need. And it's based on involving the patients in all the decision making. So that's why we've called this transfusing widely. And you can see that hematinic deficiency is treated with transfusion, which is disappointing. And I think part of the reason for that is that there's a lack of education now. Hematology training is being squeezed out of undergraduate curricula, and I'm quite surprised by the extent to which people don't know what a low MCV or a high MCV means, and patients end up getting transfused when they don't need it. Then we're trying to prevent people getting avoidable use of group O negative red cells, particularly when now they could have O positive red cells in an emergency if they're males or they're women over the age of about 50. And we pick up some of those every year. Thanks. Next one, Shruti. So we just looked over the last five-year period. The total cases identified was 56, and 80% of those were patients with iron deficiency, as you can see there. There was a much smaller number of patients with B12 deficiency, but really we shouldn't see transfusion in any of those unless they're really unwell. And then one might consider giving a single unit just to tide them over if they're in real trouble. Interestingly, none of these 56 patients had bleeding or cardiovascular compromise. And 75% of the patients, as you can see, had hemoglobins of over 50, so they probably could have waited. Next. So delayed transfusion is a very serious issue, and you can see that since we started collecting information about this, which was in 2011, after the first report from the Patient Safety Initiative drawing attention to the hazards of delays, the number of cases has increased every year, and last year the total was 133, but there was 12 potentially avoidable deaths due to delays in transfusion. Next. And if we look over the years of transfusion-related deaths reported to SHOT, you can see that the red bars are the delays and the orange bars are TACO, and those two topics together, or reports together, are the ones with the largest cause of death related to transfusion. And TACO, many cases could be preventable, but certainly delays should be preventable. And if we look at the transfusion-related deaths just in 2020, you can see that 14 were considered preventable out of the deaths, and the majority of those, that's 12, were deaths due to delay, and one due to undertransfusion, one to TACO. Next. So just moving to prothrombin complex concentrate, we collect reports of these, although obviously it's only a small number, because of concerns that we have about really mismanagement. And it's because PCCs are used as an emergency treatment for reversal of warfarin in particular. And it's really important that it's started as soon as possible, and preferably within an hour of the decision being made, particularly for patients with intracranial hemorrhage. Emergency departments really need to be sure that they know where they are and how to use them, and that the staff are trained. And the use of PCC should be audited and reviewed so that people can learn from how it could be done better. Next. Every minute counts, and as I said, give it as soon as you can within an hour, particularly for patients with intracranial hemorrhage. We've had one death reported, and we sometimes have extension of the intracranial hemorrhage in patients in whom it's been delayed. Next. So if we look at delayed transfusion, this is a busy slide, but what I want you to notice is that it starts with a hemorrhage call, then there have to be actions in the laboratory, followed by components reaching the patient. And the biggest issue in contributing to delays are communication problems, and they're manifold. There's so many different ways, and each communication issue can add minutes, so that the delays may well be cumulative. And I've listed some of the other things at the bottom: sample errors, staff shortages, that's a feature certainly this year, porter availability, bleeps not working, every which way. Transfusions can be delayed, and these should be looked at and reversed. Hospitals should really review their emergency procedures, their major hemorrhage protocols, and make sure that they work step by step from start to finish. Next. So again, this just shows you again that 71 out of all the reports had delayed transfusions with communication as a contributory issue. Next. So this recently we have issued with the MHRA an alert for hospitals to draw this to their attention and suggest actions and procedures that they need to do to try and reduce the deaths from delay. So I hope you've all seen that, and if you haven't, there's the link with the QR code. Thanks.
Thanks very much, Paula. And just the last two slides that I wanted to just cover is regarding the pediatric reports that we actually receive as well. And thanks to Helen and Anne who look at the pediatric reports that we get. Now we get it in all the different categories as well. So this is just a summary slide that from the 2020 annual SHOT report. Just a couple of things to highlight is the pediatric reports are overrepresented in those categories with the febrile reactions, the delays, the incorrect blood component transfused as well. And they overall constitute around 8.5% of the reports that are submitted to SHOT. So, it is a considerable number that we receive. Deaths can occur and have been reported even in the pediatric population. And there were 3 deaths that were reported in 2020. One was related to a transfusion-associated necrotizing enterocolitis, but significantly 2 were related to transfusion delays and major bleeding. And comes back to the point that Helen was actually mentioning, that hospitals should have the systems in place, the policies, the procedures, and the staff awareness as well to deal with this. And that was one of our recommendations to ensure timely management in these situations. Again, coming back to the same themes as we see in the adults, the communication and staff education regarding the special requirements as well as their indications remains vital. And we have had instances where the, how do we manage de-incompatible platelet transfusions, and there have been cases reported as well. So that needs to be actually also discussed, and also make use of the expertise that is available to discuss with a hematologist when facing such situations. And we continue to make those recommendations that education and training resources should be easily accessible for the staff, so that whoever is involved in the pediatric and neonatal transfusions are able to quickly access this. Should be actually these training should be able to actually be fully trained and understand the rationale for the decisions. And towards that, there are resources available from the SHOT as well. So we have a video that is covering the learning from the pediatric haemovigilance, and that QR code will take you to the video that has been produced a couple of years ago. And also the errors that we see is with the neonatal blood administration sets as well. So please, the staff need to be familiar, and aware about these administration sets, along with the special requirements for this particular population in accordance with the BSH guidelines. Also, tricky area is actually being able to recognize the transfusion reactions. Now, that can be pretty challenging in sick children, and is especially in sick neonates, and therefore how do the staff be able to identify, connect the dots, and manage appropriately. The next slide is just telling you how and where to access the annual SHOT reports, and all of the SHOT resources, including the videos, are easily available via the SHOT app, which can be downloaded on via the App Store. So that provides a quick overview summary, and we'll now open it up for discussions if all the panel members would then be coming on. And I see that there have already been questions coming through. So over to Nikki.
Hi, thank you, Ori, and thank you for those really interesting and fascinating presentations. So whilst we've got a panel of experts, so feel free if you to want any Q&As, just stick them in the Q&A box at the bottom. I can see there's already some questions coming through. So let me open the first question. This one came in quite early on from Sharon, and I think Andrew's already said he will answer this one. It said, we're still waiting on the final report on medical use of RBCs. When will that be out?
Yeah, actually, I probably should have asked John about that. It's already been finalised and approved, so it should be imminently landing on your doorstep.
Absolutely. Yeah, processing it this week, Andy, so it should be out with you by Friday.
Thanks, John.
Okay, thank you for that answer. There's a question from Nova Hippie, and I think Mike Murphy wants to answer this question. How do you check what information was given before transfusion and whether they understand the information that was given?
Yeah, thanks very much for the question. So for the audit, we wanted to look for written documentation or documentation in an electronic record. So for written information, the patient's notes, an operation notes, anaesthetic charts, we were looking for documentation. If the process isn't documented, then we assume that it didn't happen. And just one final point, John, I think I'm right that the report on the NICE quality standard audit is due to be sent out to hospitals very soon as well.
It's going out today, Mike.
Right. Okay. Thank you.
Thank you. So we've got a question here for Andy. Are there any transfusions are their transfusions generally urgent, i.e. being given in A&E and MAU in acute circumstances?
Okay, thanks. Yeah, that's a good question. And the answer is that actually not many of them were. Most of these transfusions, if this is in the medical audit, are being given on wards. So this is after people have come through the acute setting and then they've gone to a ward. So that just gives us a picture of, you know, that there is time to make these decisions. Probably about 10% of them are being made in MAU and about 10% in A&E. So those are the sorts of decisions where, you know, there might be very acute circumstances affecting why people decide to transfuse, but more than 50% were on a normal ward. So useful information just to think about, you know, why we were transfusing.
Just building on that, Andy, if I may, but having looked at that data during the seminar, and in actual fact, while there were quite a few coming in through MAU and A&E, the majority of them were not what we would call at all acute bleeding. It was things where the bleeding might have been quite minor, and certainly probably not one, Andy, that would threaten the hemoglobin and therefore lead to symptomatic anemia. Most of them seems to be these where the patients were presented, but as you just said, not really the reason for transfusion. So quite a comforting, reassuringly small number of people transfused for a good reason in A&E, the majority of them taken much later on in their care when they've been admitted.
Yeah, and related to that, about overall from all the patients audited, about 1 in 3 had a presentation that was a bleeding related presentation. Yeah. So 2/3 of patients presenting not with bleeding, but ending up getting transfused.
Yeah.
Thank you. The next question is for Helen. Can you say anything to say how practice for prophylactic FFP transfusion now compares with the finding in 2009? Comparable between the two audits?
Yeah. Well, thank you for that question. I imagine many of you will remember that there was an audit of FFP transfusions back in 2009, and that covered all age groups, and it was obviously a different designed audit to the one that we've just done. It also covered bleeding as well as prophylaxis. But actually, when you look at the group that I've highlighted as a very key group, those 75% of neonates who were transfused for abnormal clotting with no bleeding and no evidence of surgery, and look back at that audit, it is actually possible to do a comparison, because there, if you look at the group who were infants in that audit and take out those that were given FFP for bleeding, that left 66% of that group who were again transfused for abnormal clotting with no bleeding and no procedure. So it's a very similar proportion, showing there's still this very key group who are continuing to receive prophylactic FFP transfusions for an indication which in the guidance would not really be considered to be reasonable. And the question is how to get at those, how to understand better this practice. Clearly this is just audit data, we don't know precisely the reasoning. And the final point is that actually we can't compare the actual numbers of transfusions for this indication across the two times. We can say that the proportion is similar and looks important. I think it is important to address locally. But it's certainly an area to keep looking at. Thank you.
I'd like to add to what Helen's saying, and I think it's very disappointing that not just in children and babies, but adults, people are getting fresh frozen plasma transfusions that they really don't need and they're not indicated. And we know that the whole picture for liver disease, for example, has changed. And it comes from this belief that we can't get rid of, that clotting tests tell you something about hemostasis, which they very rarely do. And if I could abolish one test, it would be the general doctor's ability to order a coagulation screen, because I think they don't know what they're asking for and they often misinterpret the results.
Thanks
for that, Paula. Another question here, forgive me if I get your name wrong, from Jana van den Broek, and it says, how do you measure, or how did you measure if patients were clinically assessed between units? If someone would like to answer that question.
Shall I take that one then, Mike? So
Sure.
basically what we did here is we spelled out what the NICE guidelines say about that. The clinical assessment really is not that well defined by the NICE guidelines, but it's essentially, and this may sound surprising, but it's looking at the patient to make sure that the patient doesn't appear to be uncomfortable, as well as things like checking for shortness of breath or maybe a change in the symptoms that you might have been treating, and also then to do that hemoglobin check. And just two reasons for that, Simon, to finish the answer, is you're checking not only to make sure that you may or may not need to give that subsequent unit, but also, of course, checking to make sure that the first unit of transfusion that you gave had the intended consequences. It might be that the patient actually needs more, but it was therefore the general advice to people, these are the kind of things, but whatever you determine as being a clinical assessment. And then we just simply said to them, is there any record of that sort of thing was done? Is there any record of a repeat hemoglobin? So we gave general guidelines, but they used their own discretion as to whether or not they did or they didn't.
Lovely. Thank you very much, John.
Thank you. So I've got a question here. Sorry if I get your name wrong, from Sven. So the question is, do NCA or SHOT contain any information about how widely intraoperative blood salvation or cell saver is used, perhaps as a percentage of total blood use?
I can say on behalf of SHOT, we don't have that data. There is unfortunately, poor denominated data. We do include the reactions that have been reported related to cell salvage use in the hospitals. But I do know the UK Cell Salvage Action Group has done a recent survey to actually get some information about the extent of the use. There is a general awareness that it is not used as optimally as it can be. That is from a haemovigilance perspective. I don't know if any of my colleagues wanted to actually provide from a PBM perspective.
I'm pretty sure, I could be wrong about this, feel free to correct me, anyone else, but I'm pretty sure that part of the PBM use in surgery, which was a few years back, included information about use of intraoperative cell salvage. So if the questioner wants to have a look at that, that's on the National Comparative Audit website, the report from that.
Thank you. Super. We've got 4 minutes left, and I know we've got a poll. Do you want one? Would you like another question? Do you think we can squeeze another one?
I think you can have 2 short questions now.
Okay, I'll do a short one. Looking back at the John's presentation, are there any guidelines that actually require trusts to record that they've provided both verbal and written information? Because I could see that number was quite low, wasn't it?
Yeah, I'm going to pass over to Mike Murphy.
Sorry.
No, he's much more aware of these than I am. So, Mike.
Sorry, repeat the question. I didn't quite catch it.
Yeah, are there any guidelines that actually require trusts to record that they've provided both verbal and written information?
Yeah, and there's lots of guidance out there in the NICE guidelines, NICE quality standards, which we discussed, choosing wisely. But probably the best place to go to are the SABTO guidelines, which were published at the end of 2020. So look them up online, they're easy to find, and there's a lot of information there about obtaining consent, as well as providing information to patients about the risks and benefits of transfusion. This is a really, really important issue. It's not well done, as we've documented in the audit. It needs to be done much better. We need to include patients in the decision-making about blood transfusion. They inform them about alternatives to transfusion where they're appropriate.
Thanks, Mike.
Thanks, Mike. For the final question, it's from an anonymous attendee, and it says, in light of the current pressure on the NHS, is there any evidence to suggest that red cells transfusions are given in preference to iron infusions so that patients can be discharged earlier and beds freed up more quickly? Good question. If anyone would like to answer that.
Do you want me to start, Mike, and you can add anything? Sure. So it's a really good question. It wouldn't be a very good way of speeding up discharge, because iron infusions you can give over 15 minutes and red cells take an hour and a half. So that's not a good reason to do it. I'm not aware. So we did collect that data. What we asked people was, if you transfused people and you gave them iron, is the reason you did that because they were too unwell to wait for the iron to have effect? And we don't have all of the analysis of that, but we know that that does happen to some patients, and that's perfectly reasonable. If you think a transfusion is indicated while you're waiting for iron, that's a perfect way of doing it, because the red cells won't give them enough iron to keep them from being iron deficient anyway. So yes, I don't think there's evidence of mass use of that as a reason to speed up discharge, but as I say, it wouldn't be a good choice anyway. Mike, I don't know if you want to add to that quickly.
No, that's fine, Andy. I agree with you. And the concern is that still red cell transfusion is being used to treat patients with iron deficiency anemia, where iron would be much more appropriate.
I think as well, very quickly, there are so many good options now for ambulatory monitoring of these people as well that probably 10 years ago weren't available to us. So ambulatory care, those sorts of places can see people again to keep an eye on them. If you do discharge without transfusing, you can safety net much more easily than I think you probably could in the 2011 audit. So just to bear that in mind as well.
Thank you. So there is a quick poll for everybody, for the attendees. It's really helpful to SHOT if you do take part in the poll. It helps us target our resources and our education programs and future webinars. So if you could have a go of the SHOT-NCA poll, that'd be really helpful to us all. And whilst you're doing that, don't forget that you can download the SHOT app. We've got lots of resources on the SHOT website. There's SHOT Bites, there's previous webinars, and there's lots of information out there. If you ever need any advice as well, the door is always open. You can get in touch with us via the website. You can email us directly as well. And we do have a Twitter page as well. It's at SHOT-HB1. We are trying to push lots of information out there and try and keep people informed. We've recently started tutorials as well, so lots of interesting resources out there for people, whether you go onto Twitter or you go onto the website. And I would like to say thank you for everybody attending. I know out there in the hospital world, people are very busy and stretched and pushed, so we really do appreciate people attending and taking part in the Q&A. And thank you for everybody for participating. Thank you for the presentations, and hopefully we'll look forward to seeing you in the next 6 to 8 weeks' time for our next webinar. So I can see people are still taking part in the poll, so I'll leave that one running. But thank you for everybody for taking part.
Thanks, Nikki.
Thanks, everyone.